So for our last ACLS case, we're going to talk about an irregular narrow complex tachycardia. And in this EKG shown here, this is an example of AFib with a PVC. So as you can see, this is an irregular rhythm, no P waves seen, and also right here you can see the PVC. So in this case, the initial goal of treatment is to stabilize the patient. And to do so, you're going to use usually a non-dihydropyridine calcium channel blocker, specifically diltiazem, 15 to 20 milligram IV over 2 minutes. Repeat at 20 to 25 milligram IV after 15 minutes. While this is the first line, another option is verapamil, which is another calcium channel blocker. You give 2.5 to 5 milligrams IV over 2 minutes, followed by 5 to 10 milligram IV every 15 to 30 minutes. So the dosing does change slightly between the two calcium channel blockers. Next, another option could be beta blocker, specifically metoprolol, 5 milligrams IV for 3 doses every 2 to 5 minutes, then up to 200 milligrams per oral every 12 hours. So while, like I said, calcium channel blockers, diltiazem is the number one, verapamil and metoprolol are some other options to treat AFib with PVC. So with calcium channel blockers and beta blockers, you must be aware that they can worsen hypotension. So patients should be closely monitored while these drugs are given. And patients at great risk of developing severe hypotension, such as elderly patients, often require loading doses that are below the usual range. So combination with a beta blocker and calcium channel blockers do increase the risk of severe heart block. So once again, these are things you should be aware of. Cardioversion is another thing that can be utilized in these patients, but it must be known that these patients with cardioversion do have an increased risk of embolic stroke, due to the fact that with an AFib, you do have stasis of blood within the atria, and this can lead to a clot formation. Once you cardiovert the patient, this can then dislodge the clot, causing a stroke. So if the duration of the AFib is known to be less than 48 hours, the risk is very low, and clinicians do consider cardioversion. However, if there is a time lapse of greater than 48 hours, physicians tend to take a closer look at the patient and overall status before deciding to do a cardioversion.